Welcome to Season 4 of Inflammation Nation. My name is Peter Boyd. Inflammation Nation is a podcast from Arthritis Ireland aimed at increasing awareness and understanding of arthritis and related conditions. I'm very glad to be joined by Sandra Caulfield, who currently works as a Clinical Specialist Physiotherapist in the HSE Midwest Foot Clinic, and she's worked in the area of musculoskeletal physiotherapy for 17 years, specialising in musculoskeletal and rheumatology conditions. Sandra, you're very welcome.
Thank you, lovely to meet you.
And Yvonne Buckley, who is the Clinical Specialist MSK Podiatrist, who has been working as part of the HSE Midwest Foot Clinic since October 2020. And as part of her role as a Clinical Specialist MSK Podiatrist, she works on upskilling her podiatry colleagues and working on research, currently in the area of osteoarthritis and orthosis. So Yvonne, you're very welcome also.
Thanks for having us.
So I suppose just to get us a little bit underway, it's a very specialised and very localised, I suppose, specialty working with feet and foot health and rheumatology and all that. I'd like to hear a little bit of background maybe on how you got involved in the area, what's your kind of motivations and how you decided upon a career. Maybe Sandra, you could give us a bit of background.
Yeah, well, I suppose I started as a physio and how I got into physio was as a teenager. I had many injuries falling off horses, and I saw two fabulous physios in Limerick and Clare at the time, Mary Pole and Anne Oakley, and they'd be very well known in the physio world. And I was just so interested in how they treated me at the time and learning about the spine from them. And I did a placement in St Camillus as a rehab hospital in Limerick, as well as I think it was in 4th year or 5th year. And I followed one of my current colleagues around. I just thought it was amazing getting people up out of bed, getting them moving after strokes. So I was very interested in physio and helping people. And then from there, I suppose I worked in musculoskeletal health, women's health, sports and rheumatology when I qualified. And I kind of fell into this role. It was a vacancy that came up in the community and it suited my family life. But I'd been providing and prescribing orthotics since I qualified. I had a very good placement with a man called Frank Sheehan, a chartered physio in Limerick who's recently retired. And I got a lot of skills from him and an interest in the feet from him. And that kind of kept going throughout my career, and then this job came up and got to work with this lovely podiatrist called Yvonne. And we make a great team. We love working together, and that's what's keeping me in the job, I suppose. Lovely staff and lovely area to work and great managers and great support from the HSE.
Yeah, it's fantastic when you find something like that suits both family life but also then that you enjoy and you find somebody that to work with and bounce off as well.
Absolutely.
And there's an energy that's definitely visible that we can see. And Yvonne, how did you end up working with somebody that you enjoy working with so much as well?
Well, obviously I'm a podiatrist, so I actually fell into podiatry off of a good sales pitch when I was in Leaving Cert. But podiatry, because it's like healthcare, you're helping people, and then you're also you have the science background, so I gravitated towards that. But I obviously worked privately first and then publicly as well. And then when I joined in 2020 with the Midwest Foot Clinic, I worked with a good few physios, and then Sandra came on board, and then it was like my work wife is found. Sometimes mammy, sometimes just support colleague. But yeah, it's a lovely area, and I suppose it's such a niche kind of area because podiatry's got a lot of different elements to it. So I am obviously musculoskeletal, but other people will be more into diabetes, and obviously there's kind of kids, and then there's the routine aspect. So, but MSK is my niche, keeps me going, keeps me alive at night.
That's great, and it's such an interesting area, and something that we like. Obviously, for myself, I'm living with all different types of arthritis and rheumatological conditions, and you wonder about it and what's going on. But what are some of the clinical presentations that you would see on a daily basis? What type of things are people presenting with?
Yeah, I suppose we would see a lot, and the main condition we see from a rheumatology perspective would be osteoarthritis, and that, I suppose, as we know, is a degenerational type of pathology. But we would also see a lot of inflammatory arthritis, such as rheumatoid and the spondyloarthropathies. And then within that, I suppose, plantar heel pain or plantar fasciitis or heel spurs, patients know it, which is the first pain in the morning on your first step, and pain after sitting for a period of time. People who are on their feet and with inflammatory arthritis often get this. And then also the Achilles tendon, or the insertion where the Achilles tendon inserts at the back of the heel, that can flare up. It's known as an enthesitis. A lot of our spondyloarthropathies or a psoriatic arthritis. Then we also have, I suppose it's called adult acquired flat foot, or it's a flat foot, I suppose, where you have pain in the arch and the tendon that supplies that area, the posterior tibialis, can become inflamed and dysfunctional. They were the main, I'd say, if I to pick 3 things that I would see really commonly in this population in clinic.
Yeah. Okay. And for yourself, Yvonne?
Well, podiatrists see there's a lot of overlap, so they'd see a lot of the tendinopathies and the adult acquired foot. But podiatrists are obsessed with like digital deformities, so at the forefoot, the very front of the foot. So people are very familiar with bunions, where the first kind of moves over. Then you've got claw toes, hammer toes, mallet toes. And then a referral we get a lot of the time is called metatarsalgia, which is kind of an umbrella term for pain at the ball of the foot, and that can be a whole different type of conditions, such as like capsulitis, where there's inflammation at the ball of the foot, or as we get older, people would often reduce the fat pad that they have in the ball of the foot, and that's called fat pad atrophy. And then podiatrists have a huge role in ulcer management, so when there's a breakdown of tissue on the plantar surface of the foot, and we'd often debride things like that with a scalpel, which sounds a bit gory, but it's not. And then obviously long term, people that do end up with amputations, so podiatrists would have a big role in obviously preventing that, but also helping afterwards.
Okay, and like they're kind of at the extreme end, I suppose, for people who are living with different types of arthritis. But it's interesting you both mentioned about like the kind of the jobs that people do and being on their feet for a long time, and that can cause different pain and different things. So we would talk to a lot of people who are working in different jobs where they have to stand on their feet for long periods of time, and that really impacts on their quality of life as well, because they're getting pains and they're getting things like that. How else are people impacted in their daily activities and their overall quality of life by their feet and issues with their feet?
Yeah, I think that's a really good question. I'm just thinking of a patient we had in recently, and she's psoriatic arthritis. She works in the bakery in Tesco, and she's on her feet all from early in the morning, and they have to wear work safety shoes. And so her feet are her most bothersome part, I suppose, and she's had a really big flare-up recently. So that level of pain is very impactful in that you're very tired. Fatigue was probably the biggest thing, going home and sleeping, and then not being able to sleep that night with pain again, not being able to go for her walk for her mental health, and she knows it's important to go for her walk for cardiovascular fitness, so it has a massive knock-on effect. And even then, her daughter was serving her dinner in the evenings, her 15-year-old daughter, so she wasn't able to be the carer for her daughter. She ended up being cared for. Now, we were able to change a lot in working with her workplace and looking at her footwear in work, but it had a total ripple effect on her whole life, her family, everything.
Yeah. It's like we would often say with our self-management programs and things like that everything is a circle and they feed off one another, and if you have an impact in one place, it'll often impact in lots of different areas. And like to go from somebody who's maybe struggling in work to standing all day to struggling to walk, and their mental health, somebody else might see that as a huge distance to travel, but for yourselves, you're seeing that on a daily basis and talking to people who are going through that.
And I think just to mention as well, that lady was able to go into work and put on that brave face for those so many hours every single day, but the weekends and the evening were on the couch or in bed, and nobody else sees that. So she shares that with us, but the rest of her peers or her relationships may not know how much pain and how much suffering she's putting up with. So it is a little bit of an unseen battle at times for patients.
Absolutely. I'm sure there's hundreds and thousands of people listening who will empathise and understand exactly what you're describing there. And when it comes to somebody who comes in like that, so they're coming in with pain in their feet or what, how do you go about examining that? Is there a analysis of their gait? Is it a biomedical examination, assessment? Or what's the terminology that we would use to how you would assess somebody?
So we call it a biomechanical assessment. So that involves we do a really thorough medical history. We'd ask any medical conditions you have, any medication you're on, if you've had any operations, any surgeries, any injuries or allergies, what level of activity you're doing, what footwear you're wearing, and obviously if you've pain in a particular area, we probably focus on that and when you're getting pain and how often. And then we generally watch you walking with your shoes on, then your shoes off, and then we'll get you to stand and see if there's any asymmetries, any difference in foot posture between the two sides. And then we obviously do a lot of functional kind of analysis where we'll look at you doing particular activities like heel raises, or if there's a particular activity that causes a lot of pain, we'll get you to do that in front of us. And then we get you up on a bed or a plinth and we'll have a look at the joints, see how they're moving. We'll then double check your muscle power and the strength and make sure your leg length is all even. And then obviously from a podiatry point of view, podiatry is obsessed with blood flow to the feet, so we'll check your pulses, make sure that's going as it should. We'll often use a Doppler for that, which kind of does the waveform. And then as well, we'll look at your neurological status, so how your sensation to your feet is and how you perceive sensation in your feet. And then obviously the biggest thing ever is footwear. We'll look at the footwear that you're wearing, how much wear patterns on them, and what type of footwear you use day to day. And then obviously skin and nail. If you have any corns, calluses, we'll be noting that. If there's any nail changes, any psoriasis or anything, or fungal infections in the nail. So it's thorough. We're there for a while.
Absolutely. It really is thorough. And I suppose that's when people have come into you. But how do people know, or how often should they be kind of examining your feet? I can't say I ever pay too much attention unless there's something wrong. And is it something that we should be doing on a regular basis, or is it part of our normal routine?
Well, like you take on and off your socks every day and your shoes every day, so it should be really part of that like program. Like you brush your teeth, like you should be taking note if there is any changes to your foot when you take off your socks. Is there any areas of redness after the shoes that you wore? If there's any skin changes, if you've got blisters, if there's a new fungal infection. And then obviously we'd have a lot of patients who can't see the bottom of their foot. So we do say that like a mirror close by where you can actually have a look at the bottom of your foot and double check that there's no corns or calluses that need to be looked at, or something that's not there normally, or any kind of redness around the joints. So, but yeah, like I think we often bury our heads in the sand when it comes to feet, like don't look at them. But they're such an important piece of your body, so it should be like when you take off your socks, you take a quick check. Yeah. And I think that's the main important thing.
Okay, and something we should all encourage to put as part of our daily routine. Yvonne, you mentioned there about shoes and the type of footwear that people are wearing, and it's something that I see in my day-to-day role with Arthritis Ireland is people talking about footwear and what should I do and where should I get the support and what's the best brand and all these sorts of things. So maybe, Sandra, you could kind of describe to us what people should be looking out for, what's the pitfalls, what are they kind of looking for when they're choosing maybe different footwear, but also for different activities. Should we be getting all sorts of different types of shoes for different activities?
Well, I think that is probably, when I ask patients, what do they want from me? They're like, what should I be wearing on my feet? It's the most commonly asked question we get in clinic, particularly from this population. And I suppose what we need to think about is why do we wear shoes? What's the purpose of footwear? And the aim is really to protect the foot, to support the foot, and particularly, I suppose, in this population would be also shock absorption. So we can, I suppose, protect joints in the feet. So their comfort is the most important thing, and the appropriate fit and the size, and we can talk about that a little bit more. But I would often say, to go shopping in the evenings when the feet are a little bit larger and there's a little bit of swelling in the feet, and then to try on the shoes in the shop for as long as possible, for 15, 20 minutes if you can. If there's a treadmill there, use it. If not, just keep walking up and down. And don't buy the shoe if there's any bit of sliding, any bit of discomfort, make sure you're comfortable in it before you buy it. Don't feel you have to buy it because they've bought out 10 different shoes to you. And then the other thing that a lot of my patients will do is bring the shoe home in the box, wear them around the house. And you have to check the returns policy, but most shops will take the shoe back once it hasn't been worn outside, wear them at home, for a few days, and make sure they're still clean, and then you know whether to take them back or to keep them, or maybe you need a half size smaller, a half size bigger, Yeah. But there's a lot of elements, so we'll go through a little bit of a checklist maybe. The first thing I would say when you go into a shoe shop, and this I've done this with both my parents recently, and they didn't go for the shoes that I thought they might, so it's so individualised. But to pick up the shoe and see, is it too heavy for you or is it light? So depending on if you have a lot of muscle wasting, a lot of pain, you want a really light shoe. So some of the runner type shoes are very light now. They're much lighter than, say, the ones that we provide in clinic. Then checking the back of the shoe, so where the heel is, and squeezing that should be nice and stiff, so that when you put it on, your heel is sitting nicely in that and it's supported in there, so that should fit well. Sometimes with a narrow foot you might have to kind of adjust with adding little plasters on the inside and stuff, but you're trying not to. You're trying to get the best fit for you, and then we would do the adjustments if needed. in the midsole, when you grab the shoe and you try to squeeze or bend the shoe, we like a bit of stiffness at the midfoot. Now, sometimes we recommend stiffness through the whole shoe. So if you have a lot of pain at the front of the foot, at the ball of the foot, as Yvonne was describing earlier on, a rocker soled shoe would be better. And we can talk about brands in a minute around that. We want to be able to take out the sock liner or the insole that's in the shoe so that you can put in an orthotic if you need one. And the other big thing for a lot of our patients, but if they've hip problems, they may not be able to bend down to put on the shoe, or if they've hand problems, they may not be able to fasten the shoe. So looking at the ability to fasten the shoe. So we provide a lot of footwear with Velcro straps, but in the shops then, it's a little bit harder to find the right shoes. So there's some really good options online where you can look at elastic locking mechanisms or metal tying or magnets. And I found a really nice shoe shop last night online, shoelacesshop.ie. It's an Irish-owned brand, and they have various options with the videos on how to use them and different laces for different types of shoes that'll make it easier for patients with hand arthritis as well to tie the shoe. So that's really important for patients, because there's no point putting on a shoe and then not being able to tie it.
Absolutely.
Because then you're losing the effect of the shoe. The sole is another big element. We want good grip, good shock absorption, and this is where it comes into different activities. So if you're not doing a whole load of walking or running and you're just maybe seated at a desk, you don't necessarily need a huge amount of shock absorption. But if you are going for a walk or a run, you're looking for more shock absorption. And with that then comes stack height, or the height of the sole of the shoe. Generally over 3 centimetres or 3 fingers is quite high and can lead to instability. So if you're someone who's had ankle sprains or have other issues going on, or a little bit of instability in the knee, that might be too much for you. But the only way you'll know is by trying on. So like for instance, the Nova Blast, the new Asics Nova Blast is over 4 centimetres. Some patients would love that. Some patients won't like that at all. The Hokas are about 3 centimetres. Patients love the Hokas. The Hokas and the Asics tend to be for a narrower foot. Now you can get them in wider fits, but they're hard to get in Ireland. The Brooks tend to be a little bit wider. And then a lady might buy a men's Brook, for instance, and you can do that with the Hokas and the Asics too, which are a little bit wider again. But you can also get the wide fit in the shops for Brooks, which is very helpful. So it ends up being kind of maybe more of what our patients lean towards, because they often would have a wider forefoot. And then they have Gore-Tex options as well, which is brilliant, But I would say if you're doing strength training, you're looking for a less of a stack height or less of a heel height. If you're doing Pilates and yoga and you're happy to be in your bare feet and you don't have any sensation issues and the environment is safe, bare feet is best, but maybe that's not something that's achievable for you. So you can get gym shoes, you can get kind of a softer sole type runner for that, So there's lots of different options, it's very individualised. It has to be comfortable, it has to be the appropriate fit.
Yeah, no, that makes a lot of sense, and it's interesting when you get into it how individualised it is in one sense, but there are some things that are kind of important for everyone. I'm just thinking, we bring our kids to get their feet measured and check how wide they are and what size they are, and make sure that we get the right fitting shoes for them. Do we do that enough as adults?
We don't. We don't. And there's a lot of research on this. And I suppose before we wouldn't have realised, and even I was giving an in-service to our physio team, and the physios didn't even realise that we change foot shape as we get older. So there's a nice piece of research done in the UK last year, and they looked at 200 ladies between the ages of 18 and 80. And essentially what they found was that the arch height drops, which kind of widens and lengthens the foot, but also the forefoot becomes wider as we age, and that's without any medical conditions. So then if we have arthritis, for instance, or an inflammatory arthritis, oftentimes our forefoot will widen as well. So, and then, perimenopause, postpartum, we'll change sizes as well. So really we need to be fitting. Every time we try on a shoe or we go shoe shopping, we should be trying on for a different size. And the other element that's changed as well with Brexit, we've seen, and what patients would report to us, but as well personally I've seen, sizes have changed a lot. So each different brand will have, like, I know Adidas has a 6.3 or is it 39.3, which means it's a wider, rounder toe box. And then within New Balance, for instance, the 39 might be a 39.5 or 39. So they're all a little bit different, and even within each brand or each model within each brand is different. So you have to try them on. Yeah. So that's why online shopping doesn't work unless you're doing a repeat buy and nothing has changed.
Yes, yeah. So you have to be very careful with all that. Very important, even for that. And looking at the kids side of things as well, so you have kids coming in with inflammatory arthritis or hypermobility. They're all looking at things like this as well. But orthotics are something that's kind of mentioned a lot when people are talking about foot health and things like that. What are they? Are they important? Should we have them? Or should we all have them? Should only certain people have them? What's the view on them?
So orthotics are great, but not everyone should have them. Not everyone needs them. Orthotics, basically what they do is they kind of alter forces and pressure in your foot. And even on a professional level, like no one knows 100% what they do. And that's very honest answer from a podiatrist. But like they are really helpful for people with any arthritis because they do reduce plantar pressures, especially in the rheumatoid population. And they have been shown to be of benefit. But like there's a lot of different types of orthotics. They have a lot of different materials. They can come in a prefabricated or off the shelf, which is really fast and easy. Can be great for short-term rehab. And then there is customized devices which are more expensive and they're meant to measure to your foot. But basically not everyone needs them. You should only really be looking at them if you've got pain or if somebody has recommended them. And sometimes people don't get on very well with them even if they're prescribed. But they do have benefits, but it's just you shouldn't go in and think that you need an orthotic just because you have a condition like arthritis, or it should be based on pain and recommendations of a person.
Yeah, no, that's fair enough. And because like we would often hear, and I've had people who would say, oh well, that will solve the problem, or that'll do that. But I'd imagine there's all sorts of different areas through the body then that you're destabilizing and you're changing the movements. It's
a domino effect. Like our foot, like our knees and our hips, they all work together in tandem. So if you're rushing in with an orthotic, you have to consider the knees and the hips and all the forces that will go up along. So it should be done based on an analysis. The biomechanical analysis should guide whether you actually need an orthotic or not, or maybe you'll need a strengthening program. It's not a fix-all. It's generally used as part of a treatment program. Mm-hmm. It's not there on its own. And generally, if they solve the footwear issue, there's no need for an orthotic.
Okay. And we described kind of all the different maybe treatments or investigations and different things that might be done on that. But I'd imagine staying on top of your foot health, as you said, every time you take off your shoes and socks, having a look at your feet, checking all that. Early intervention and early kind of seeing any problems at their earliest point, that's probably the best that we can do, similar to an arthritis as well.
Yeah, if you can start a treatment plan looking at your foot and ankle early, then you can reduce structural changes, joint damage. You can improve your quality of life earlier. There's nothing worse than seeing a patient who you wish you saw 5 years earlier, because that's it's a totally different treatment plan. So it's very important to try, and if you feel like something's wrong, to go early rather than to leave it and hope that it'll get better yourself. And getting a diagnosis from a professional like a podiatrist or a physiotherapist can lead you in the right direction earlier, so you're not suffering in silence.
Yeah. But is there anything that we can do, kind of like if we don't see anything, or like is there any preventative measures that we can take, or any daily activities that we can do to maybe ward off any issues with our feet?
Good footwear first and foremost, okay. And then I suppose activity, which is where I'll let the physiotherapist answer that one, because physios.
I suppose when we talk about activity, we're trying to stay active, and if you've been unwell, if you've had a flare, it's rebuilding yourself gradually. But certainly, if you look at the webinar that we did actually back in September, or even the Arthritis Ireland Facebook page, Karen Quinn, who's an excellent clinical specialist physio down in Cork, has done some exercises, basic calf raises, whether you're sitting down or standing, pressing your foot into the ground and squeezing your calves to lift your heels. That's a great overall strengthening exercise for the back of the leg. Sit to stand off the chair, getting up off the chair without using your hands as many times as you can until your muscles are sore and tired, and then repeating that. And the important thing about these exercises is that you're progressively overloading them. So if you could do 10 today, say for instance, Peter, tomorrow you try and do 11. And you try and keep building that up until you're at a set of 20, and then you kind of go, okay, can I do 2 sets of 20? So you're constantly challenging your muscles but that they are kind of great ones. And then just stretching the calves while you're brushing your teeth. I say to patients, it's habit stacking. That's very popular at the moment in social media, but it's that while you're brushing your teeth, you could be stretching your calves, because that's probably one of the main, when we look at patients that come in and we've audited our work, the calves being very tight is one of the things that we see a lot, especially with our female population, but also with the gents. If you've had a synovitis, you've had a flare, the muscles around that do become a little bit tight and weaker. So we're trying to keep that flexibility in the joint is very important so that we can get our heel to the ground when we're walking. But again, good footwear will compensate for that. So it all comes back to wearing the right shoes. And as Yvonne said, oftentimes when patients come to clinic, we give them that bit of advice around footwear. We ring them a month later, they're pain free. Do you know, it depends on the patient now, but a lot of our patients.
Yeah, if everyone was wearing like the correct footwear, we'd have a quieter job, I think.
Yeah, and I think compared to, when I qualified 20 years ago, there's a big difference, that medication's making a big difference with a lot of the inflammatory conditions we're seeing. So we're not needing to have as much intervention. We're not needing the orthotics as much because we don't see as much joint destruction as we have previously. So yeah, we can be a lot more conservative now thanks to the pharmacology.
And when you mentioned pharmacology and medications and things like that, is that the main area of difference now that you're not seeing as much maybe destruction of a joint as you would have previously, but is there anything else that people can do? Is there any kind of supplementation that would help with bones or joints or anything like that?
Yeah, it's a good question. I suppose you look at the research, there's very little RCTs, like the randomised control trial that we like to look at the big high level evidence. There's very little around that. A lot of patients like to take glucosamine and collagen supplementation to support the collagen, which is technically supposed to support the cartilage in the joints, but we know maybe there's other ways of supporting cartilage than taking supplements. So there isn't enough evidence around that. I suppose the omega-3s have and 699s have a little bit of research to support them. I know the rheumatologist, Dr. Devlin, I used to work with, used to always say, there's no harm in taking the supplement, but there isn't a lot of evidence behind it. So sometimes you might be wasting your money. And really, I think it's best to talk to the pharmacist or the medics around the supplementation. There isn't a huge amount of, a little bit around cherries as well, but that was on Norway years ago, I think about 10 years ago, but there hasn't been follow-ups on those, so yeah.
Yeah, no, it is about trying to maintain that, and we've talked a lot about different things. You've mentioned repeatedly that good footwear will do a lot of things to prevent and to maintain good foot health. But is there anything else that we can do to prevent the damage to our feet? Is there anything that you haven't mentioned that you'd like to bring forward at this point?
I suppose the big podiatry thing, I suppose, is the skin, minding that skin early. Appropriate use of moisturisers and stuff is a big part of it. We'd see a lot of patients probably further along with rheumatoid arthritis who often have nodules on their foot. And an issue we sometimes see is they think that the nodule, which is like a lump on the bottom of your foot, is kind of a callus or a corn that needs to be removed. But sometimes that's protective in nature. But again, that's more like going to the right person will tell you that, and using moisturisers to keep the skin and tissue viability really good. And seeking that help, because sometimes as well with people who have a corner callus underneath can be quite spongy, and that sponginess could be something underneath the callus and corns. It's kind of like that film What Lies Beneath, so you need to double check what's there versus going on and just assuming that moisturising and paring it back yourself. So going to a podiatrist who can debride it back and tell you, yes, there's something underneath that, like an ulcer that's developing, and that's more in stage kind of stuff. But it's a problem that we do see where the tissue in between the cells kind of can bleed and break down. And then I suppose the big thing that I'm always like, nail health wise, double checking that there's no single black line on the nail, because that can be an indicator of a melanoma. But obviously get that checked with your GP or with a podiatrist early on, just to prevent. It's all about early, doing things early.
Yeah, getting in early.
And I suppose from a physio perspective then, it's physical activity. It's really important that we don't deload ourselves, that we don't become inactive, because there's some really interesting research going on in UCL in London. There's Professor Tanya Vincent, and she's an honorary rheumatologist, and she's looking at the cellular changes that happen with OA on cartilage. So cartilage is kind of the packaging, smooth material at the end of our bones within our joints. And we've always known it's there. We talk about our meniscal tears, and we've always kind of thought it's shock absorption, and that's kind of its role. But what she's been finding out for the last 20 years is, but this is kind of new enough research for us, I suppose, as clinicians, is that it's mechanosensitive. So within that there's a little cell called the chondrocyte, and the chondrocyte responds to mechanical stimulus. So what that means is if you had the flu, Peter, and you were in bed for 2 weeks with the flu, and we x-rayed your joint and we saw the cartilage would get a little bit thinner. Okay. But say for instance you're walking 10,000 steps a day, and we looked at the cartilage thickness, but then you added, say, maybe squats, and you were loading it beyond what you normally load your cartilage, then your cartilage thickens. Wow. And the really interesting thing that is for people with arthritis is when we x-ray joints and we look at the joint space and we look at joint space narrowing, that correlates with the patient's pain. So if we can thicken up the cartilage slightly and maintain health, and we're talking about like early intervention here, so if we are doing this strength training twice a week and we're doing our aerobic activity, we're potentially keeping the cartilage nice and healthy. And that's where we're at. Now, it's a little bit nuanced. So, for instance, if you were someone who had an inflammatory arthritis for many years before it was caught, and you've had many flares and many synovitis in the joint, and the joint's been hot and warm and swollen, and it hasn't been managed well, you might have a laxity of the ligaments around the joint. And so the joint might move a little bit, and around that again, your muscles might be a little bit weak. So if you decided, Sandra said in the podcast, I could go pound the stairs now and get on the cross trainer, you could be causing shearing forces there because you might not have the muscular support to support the joint. So if we can get the right person to do the right exercise. So again, if in that case, you probably have a painful joint. If you saw your physio could give you nice graded up exercises to build up your quads, your calves, your hamstrings, for instance. And then you could start doing your squats and heavier weights. Then that's a very safe way to do it. But we don't want shearing loads that would degrade the joint. We want pounding, nice strong input into the bones and into the cartilage. And again, that also helps our bone stress modelling, so it prevents osteoporosis. So I think that's huge. We think foot health, but actually it's everything. And then it's your cardiovascular health, your mental health, it's your whole well-being.
It's the whole package in one, and it's really important. All of those things are. It's just interesting. One thing you mentioned there was osteoporosis and something like that. So it's something within our community we would have a number of people who would be maybe osteopenia or osteoporosis, and is preventing falls. Is that part of your role, maybe to kind of talk to people about that? Preventing damage, preventing breaks particularly around the ankle and the, I don't know how many, there's a lot, I think, joints within the foot itself. So is it quite delicate if somebody was to have a fall? Or the
foot, it'll be okay. It's the radius and the hip and the lumbar spine that would be the higher risk of osteopenia or osteoporosis. But we know, I suppose, if we have weak toe flexors or a weaker foot, our balance is less. If we have, for instance, reduced sensation in the foot, like the peripheral neuropathy Yvonne was speaking about earlier on, we often have a wider base of sports. We'll put our feet out wider and we're more likely to fall. So yeah, it's a massive part of our role, absolutely huge. So again, it's footwear. I had a patient there the other day and she's doing great. She had a fall abroad and she's doing really well, and she bought all the right shoes and we got her into the right orthotics. And she goes to work for 3 hours a day, and then she comes home and she puts on her slippers and she's in agony. And her slip-ons as well. So that's a risk of falls for her again. And she's already recovering from a fracture. But also it's causing her more pain. So it's actually having the appropriate house shoes. So sometimes it is having, going into certain shops, buy one, get the second half price, have this half price one at home for your house shoes. So they have a back, that have a good grip. Not walking around in your bare feet, particularly if you've peripheral vascular disease or any sensation loss. Yeah. And then not walking around in socks. Socks falling down the stairs is a big one. Any rugs or mat, take them away or else stick them down. Any trailing flexes, take them out of the way. If you have a step and you have flares every now and then, put a handrail beside your step. You can get a physio assessment, you can get a home visit physio assessment, or you can get a home visit OT assessment. And both of those professionals will be really able to help you with the home environment. And then if you've been given a walking aid, particularly if you're going out and about, use the walking aid, because you don't know when you get to the curb where you're tired and you're carrying a shopping bag when you might fall. Yeah, you're at high risk. Yeah.
Okay. Okay. It's interesting. I knew we were talking obviously about foot health and rheumatology. I didn't really pay enough attention to how much falls and fall prevention would be an important part of both of your roles to try and ensure that you're not getting that damage. How do people access podiatrists and specialist physiotherapists to get their treatment?
It kind of varies across the country, but like first and foremost, podiatry, you can go on Podiatry Ireland and there's a lovely website and you can find a podiatrist, and they're CORU registered professionals, so that's the first place to go. I suppose from a HSC kind of point of view, there's varying levels of access to podiatrists. We're a small profession. They're crying out for podiatrists. So if you know anyone that wants to become a podiatrist, there's a 4-year degree in Galway and 2 years masters. So yeah, like it can be difficult to access a podiatrist from a HSC point of view, but there are private practitioners who are really good. It's just to make sure that they're CORU registered, and to Google on Podiatry Ireland, and they will run through a lot. Like some of them have niche areas, but a lot of private practitioners are really good at those MSK kind of presentations, and will also have a great knowledge of those skin and nail and all the corns and calluses that you can get. And then chartered physiotherapist, Sandra?
Yeah, so chartered physios, there's different in this country, like internationally, physiotherapists are known as physical therapists, so there is a slight difference. And some physical therapists, they'll undergo a degree and everything, they're just slightly different trained, and some of them are well able to manage this condition. But I'll just talk about chartered physiotherapists. We're all under the same umbrella, under CORU. So generally, I suppose if you have an inflammatory arthritis or you're involved with the rheumatology department, your rheumatologist will be able to recommend, or will have a physio on their team. Depends on where you are in the country. I know some places are very well staffed that once you have a diagnosis, you're seen by the MDT or seen by the nurse, the OT and the physio. That's not always the case. I know currently it's not the case, say, for the Midwest. So your consultant will be able to recommend private physios they often will refer you to, or they'll refer you to primary care physiotherapists. And I suppose chartered physiotherapists will be employed with the HSE. That's another difference in that, we have that kind of regulation around our training for being able to assess every system, the respiratory system, the cardiovascular system, which is important for people with rheumatology. So primary care teams, each primary care team will have a physiotherapist. So your GP or your rheumatologist can refer you there, again, privately. You can go onto the ISCP, so the Irish Society of Chartered Physiotherapists website, and they'll have a list of all the private practitioners in your area. And then I suppose if it is foot and ankle you're looking for, it's having that conversation. Are they comfortable assessing you? So some physios, like from the get-go as a student, I trained up in orthotics, so I have that experience. I was very, very lucky with who I'd worked with and where I had placements. Not every physio would be happy with doing that, and even your physio can recommend someone in your area then who'd be more appropriate around the foot and ankle if it's specific to that. But every physio would be trained in rheumatology. Yeah.
Excellent. Well, it's fascinating. It's really interesting. We've had a brilliant discussion. I really appreciate both Sandra Caulfield and Yvonne Buckley joining us on Inflammation Nation. Thank you so much.
Thank you.
Thanks for having us, Peter.
That's all from this episode of Inflammation Nation. Don't forget to subscribe on Apple Podcasts, Spotify, or as they always say, wherever you get your podcasts. For further information about arthritis, you can visit our website, arthritisireland.ie, or contact our helpline on 0818 252 846. See you next time. Inflammation Nation is supported by Pfizer and AbbVie.